Good morning, everyone, and welcome. This is Mark Erkin, and welcome again to our Friday morning program. We are rapidly coming up to our 100th session of our Friday programs, which started at the beginning of this pandemic back in 2020. It is a wonderful milestone to be approaching. Unfortunately, I wish I could say that that the pandemic is reaching some better milestones, but wherever you are, I hope that things are safe and that you are all healthy. We have a great program this morning that is on a topic that's extremely important, and we have the pleasure of Dr. Elisa Pasqual, who is a postdoctoral fellow in the radiation epidemiology branch at the National Cancer Institute. She is actively engaged in research related to thyroid cancer epidemiology, cancer etiology, and radiation effects. Her research includes the risks of second cancers following radioiodine therapy, and also exploring an association between obesity and thyroid cancer. Both topics we are open for questions. And so, as always, I encourage all of our listeners to send in questions that we will try to get to before the end of the hour. Dr. Whitney Goldner is our discussant this morning. She is an endocrinologist at the University of Nebraska Medical Center. Her major interests are in thyroid nodules and thyroid cancer, as well as other endocrine tumors. She is the principal investigator of a cancer bioinformatics registry and a biospecimen bank at the Fred and Pamela Buffett Cancer Center. She is very busy on a national and international level. She is a member of the board of directors for the Endocrine Society and a member of both the ATA and NCCN Cancer Guidelines Committee. And so with this, I'm going to turn over the program to Dr. Pasqual and thank both of our participants and panelists this morning for their presentations and for joining us, and look forward to your presentations here. Elisa?
Thank you, Dr. Erkin, for this introduction. I am really grateful for the opportunity to speak today, and I am Elisa Pasqual, and I am a medical doctor by training, but I choose a career in epidemiology. So, and I'm currently training as a postdoc at the National Cancer Institute. And I'm saying this to underline the fact that my expertise is on the epidemiological aspect, not on the clinical. So I have nothing to disclose, and the learning objective of today's presentation is to describe the trends in treatment for adults and pediatric localized papillary thyroid cancer in the United States between 2000 and 2018, to evaluate these trends in the relation to the American Thyroid Association clinical guidelines recommendation, and also to discuss strengths and limitation of using SEER database, which is the the United States Cancer Registry for this type of analysis. The results I will present today are published in Thyroid, and I give here the reference for those who want to follow from the paper. And the story of today is really has to start from this graph, which shows how the incidence of papillary thyroid cancer has increased dramatically in the last 30 to 30 years, especially for the smallest 0 to 1 centimeter, 1 to 2 centimeter papillary thyroid cancer. And this observation has raised the concern about overdiagnosis, also because there is also this other observation where because of that increase in papillary thyroid cancer that we see in the slide before, there has been an increased incidence in all thyroid cancer rate, but this increased incidence has not been accompanied by an increase in mortality rate. So overdiagnosis is defined by the National Cancer Institute as the detection of cancer that will never become symptomatic and for which treatment is not needed. And the treatment of overdiagnosed cancer is by its definition overtreatment. And strategies to limit the harm from overdiagnosis has included strict strategies to limit overtreatment. So the American Thyroid Association guidelines have increasingly adopted strategy to de-escalate treatment for low-risk thyroid cancer. And in the next few slides, I will briefly review those changes for adults and pediatrics, which basically includes the limiting the use of radioactive iodine and the promotion of alternative to total thyroidectomy. So in the American Thyroid Association 2009 guidelines for adults, there were recommendations against the use of radioactive iodine, and as a surgical treatment, total thyroidectomy was indicated, and also lobectomy as an option. And these indications were for microcarcinoma localized to the thyroid. For 1 to 4 centimeter intrathyroidal the differentiated thyroid cancer, total thyroidectomy followed by radioactive iodine was recommended in 2009. In 2015, lobectomy became the preferred option for microcarcinoma. As alternative to this type of surgery, total thyroidectomy is recommended, and also active surveillance started to be indicated as an option. Radioactive iodine is not recommended for microcarcinoma. There are recommendations against its use, and also for 1 to 4 centimeter intrathyroid differentiated thyroid cancer, radioactive iodine should not be routinely used. As a surgical option for 1 to 4 centimeter intrathyroidal differentiated thyroid cancer, total thyroidectomy or lobectomy are indicated as an option, as options. For pediatrics, the recommendations are a bit different. First of all, the first publication of guidelines in pediatrics are the 2015 American Thyroid Association guidelines, which indicated as surgery total thyroidectomy. And radioactive iodine in the pediatric guidelines is indicated when cancer is spread to the lymph node or as metastasis. However, there are no clear recommendation against use of radioactive iodine for 0 to 4 centimeter intrathyroidal differentiated thyroid cancer. And so the recommendation against use of radioactive iodine for this population are less strong than what is indicated for adults. And the subject is a bit more controversial in pediatrics. Before 2015, there was a general consensus within expert opinion that pediatric differentiated thyroid cancer, 0 to 4 centimeter intrathyroidal, should be treated with total thyroidectomy followed by radioactive iodine. So in our study, we were interested in answering the question on how treatment for adults and pediatric localized papillary thyroid cancer changed in the United States between 2000 and 2018. And particularly, we were interested in looking if radioactive iodine declined after 2015 in adults and in pediatrics, as there were a little data after 2015 on radioactive iodine, especially considering the changes in recommendation for radioactive iodine. We were also interested in seeing if lobectomy and active surveillance increased after 2015. And also we were interested in exploring differences in trends across different demographics, such as, for example, age, race, ethnicity, or insurance status. So we used 18 of the SEER registry, which are the US cancer registry, that cover a period between 2000 and 2018, and that cover the areas that are colored in this map. We selected first primary papillary thyroid cancer, localized to the thyroid, and you will see that the analysis will be focused on those that are less than 4 centimeter. Localized in SEER database means that it's confined to the thyroid. And as you know, the SEER database is a cancer registry, and the cancer registry do not collect detailed information on the clinical aspect, such as, for example, the degree of vascularization, the patient's comorbidity. So by focusing our analysis on papillary thyroid cancer localized less than 4 centimeter, we were hoping to include mostly these low-risk thyroid cancer, papillary thyroid cancer, for which the American Thyroid Association recommended this de-escalation of treatment. We evaluate first course of treatment, and in SEER, first course of treatments means the most definitive treatment before recurrence. What does it mean? It means that, for example, if a patient receives lobectomy for his first primary papillary thyroid cancer, and then because of the results after surgery, it is then decided to proceed for a total thyroidectomy, that patient will be recorded in SEER as having received total thyroidectomy, because that's the most definitive treatment within the first course of treatment. Another case is a patient who received for his first primary papillary thyroid cancer is lobectomy, and then a few years later, because of a recurrence, a total thyroidectomy is performed. In that case, SEER will be recorded that patient as having received lobectomy, because that's the most definitive treatment before recurrence. Another precision is that SEER do not collect active surveillance as a separate treatment strategy. So we use no surgery as a proxy for active surveillance. But of course, this variable also includes patients for which surgery was not performed for other reasons, such as multiple comorbidities or limited access to care. So we included around 36,000 patients to receive total thyroidectomy followed by radioactive iodine, 46,000 to receive total thyroidectomy alone, around 18,000 to receive lobectomy, and around 1,000 to receive no surgery, and a little bit less than 3,000 to receive other unknown treatment. And with other unknown treatment, these include treatment other than these categories, and also if, for example, surgery, it is unknown if the patient receives surgery. In this graph, I show the distribution of size across different treatment modalities. So for total thyroidectomy alone and lobectomy, most patients have a microcarcinoma. And then for all other treatment modality, more or less, we have around 20–25% of microcarcinoma, 40% 1 to 2 centimeter, and another 30% 2 to 4 centimeter, and then around 10% and even less for total thyroidectomy alone and lobectomy of patients with intrathyroidal papillary thyroid cancer more than 4 centimeter. This is the distribution of age across different treatment modality. Most of patients are young adults, and a very little percentage, less than around 1%, are younger than 20 years old. And this is really reflecting the thyroid cancer epidemiology. This is the distribution of race ethnicity by different treatment modality across the whole period of observation. And as you can see, the distribution of races and ethnicities is really similar across all treatment category, with the exception of this no surgery category, in which there is a lower percentage of non-Hispanic white, a little bit higher percentage of Hispanic. This is include all races, and also of non-Hispanic Asian Pacific Islander. In this graph, I show the treatment proportion of different treatment modality by years of treatment for 0 to 4 centimeter localized papillary thyroid cancer, and for more than 4 centimeter localized papillary thyroid cancer. For more than 4 centimeter localized papillary thyroid cancer, we don't see any trends across the whole observation period. We see a lot of noise here, but this is because this group, as you remember, is a bit, it's not that big. However, for the 0 to 4 centimeter localized papillary thyroid cancer, we clearly see the decrease in the use of radioactive iodine, who peaked around 2006, the increase in the use of total thyroidectomy alone, and until about 2015, after which it seems that there is a kind of plateau. And also we see a decrease, a slightly decrease of lobectomy starting in 2000 until about 2008, and then a stabilization, and then an increase again around 2015. We don't see any trends for the no-surgery category. If we break down further the 0 to 4 centimeter category, we see that for microcarcinoma, we see that radioactive iodine declined substantially. It's about 6% of use in 2018, sorry. Total thyroidectomy increased until about 2015, after which stabilized. It's really clear now that the stabilization after 2015. And then for lobectomy, we kind of see this, again, this shape where we have a slightly decline until about 2009, stabilization, and then an increase again. Similar trend can be seen for 1 to 2 centimeter and 2 to 4 centimeter intrathyroidal papillary thyroid cancer, with the difference that the decrease of radioactive iodine started much later for the 2-4 centimeter localized papillary thyroid cancer around 2015. And also that the decline of radioactive iodine is more pronounced after 2015 for the 1 to 2 centimeter localized papillary thyroid cancer. This is the treatment trends by age of treatment. So this is for patients younger than 20 years old. There is a lot of noise here due to the size of the group, but we can really see the decline of radioactive iodine starting around 2009, the increase in total thyroidectomy alone. And it's unclear if there is really a trend for lobectomy. For young adults and for older adults, the trends in pattern are overall similar. Trends are also similar by sex, and also overall similar by race and ethnicity. Overall, also trends are also similar by residency in metropolitan countries and non-metropolitan counties. Metropolitan counties as defined in series counties with more than 250,000 population. In SEER, the insurance status is available.
I'm sorry that we've had a brief interruption here, I think. I'm not sure if this is a problem with Zoom or a problem with Dr. Pasqual. I think if what we may do is have Dr. Goldner be prepared to start her presentation here if there's a problem with Dr. Pasqual logging back on here.
Sure, sounds great. Just let me know what you need.
All right, let's give her just a few more seconds. I think maybe in the interest of time, Whitney, maybe we'll have you start. And then if Elisa is able to get back on, we will let her finish up here after she gets back. Okay. Lily, are you able to switch share screens here for Dr. Goldner?
Yeah, Dr. Goldner, you should be able to share.
Perfect. Okay. Are you able to see that?
All set. You bet.
Okay. Well, so I'm Whitney Goldner. Thank you again for inviting me to discuss this paper. And as I was telling Dr. Pasqual before we got started, this is a fantastic paper. And so I really enjoyed not only reading it, but kind of thinking about, you know, why were the trends that they saw things that had been going on. So I'm sorry that her slides got cut off, but I did summarize a couple of the findings, which might be helpful that she had not gotten to yet. So I want to congratulate Dr. Pasqual and all of the authors for a great paper. My disclosures, nothing necessarily relevant for today's discussion, but as Dr. Erkin said, I am on the guideline committee for thyroid cancer for NCCN and the ATA currently. So one of the things that struck me that Dr. Pasqual noted early on in her presentation is we all are familiar with the concept of overdiagnosis and potentially overtreatment then because of overdiagnosis of thyroid cancer. And so she highlighted the, you know, kind of an initial paper that brought everybody's attention to this, which was in 2006, showing that the rates of thyroid, the incidence of thyroid cancer had increased about 2.9-fold from 1973 to 2002, and most of those were small papillary thyroid carcinomas. That then was again confirmed and discussed in a paper in 2017, which looked at similar things, but also looked at reported mortality. And they reported that the thyroid cancer incidence had increased by about 3.6% per year, but this was in all stages. And actually there was a slight increase in the incidence of incidence-based mortality overall. And so a lot of this appears to be overdiagnosis, but there may be a true increase in incidence. One thing that struck me from this paper is, if you see here, they looked at 105,000 patients with localized PTC from the SEER database, and 98% of them were less than 4 centimeters, which makes sense because that's what they targeted as their population, but 50% of them were less than 1 centimeter. So I guess that struck me as a very large proportion of these low-risk tumors that we are diagnosing, because for the most part, we're not going to be feeling these 1 centimeter tumors unless they're very superficial. And so that, I think, speaks to the trend of overdiagnosis. Okay. So looking at then the guidelines, Dr. Pasqual had mentioned that in 2009, we started to recommend a de-escalation of treatment in the micropapillaries or less than 1 centimeter. Lobectomy was introduced as an option, and radioactive iodine was no longer recommended. And then in 2015, less extensive surgery overall, being lobectomy was preferred for less than 1 centimeter and equivalent to total thyroidectomy for the 1 to 4 centimeter tumors, which was really a big move to say that people could either do both, or either lobectomy or total thyroidectomy, and they would be equivalent in tumors all the way up to 4 centimeters if they otherwise appeared to be low risk. And introducing the concept of less radioactive iodine for low risk tumors also that did not have other higher risk features. Now, as Dr. Pasqual mentioned, we don't have all of those other features in the SEER database, but by looking at size alone, they were trying to capture who would fit into a low risk category based on size alone. I did not bring up every guideline, but I wanted to look into and bring to people's attention, like, what are some of the other guidelines out there? And the ESMO guidelines published in 2019 were essentially consistent with the 2015 ATA guidelines, specifying that lobectomy for T1 and T2 without other aggressive features was indicated. And NCCN is also consistent with that. Okay, so the findings of Dr. Pasqual and her group, to summarize them, basically the major change from 2006 to 2018 was a decline in the use of radioactive iodine overall from 38% down to 18%. They saw an increased number of papillary thyroid carcinoma treatments with total thyroidectomy alone, going from 35% up to 54%. And lobectomy had an initial decline early in the 2000s, before the first 2009 guidelines, then stabilized and then rose from 2015 to 2018 up to about 24%, but certainly was not the predominant therapy seen. Specifically in the micropapillaries, there was a decrease in the rates of total plus radioactive iodine from 26% to 6% from 2007 to 2018. And total thyroidectomy alone rose until about 2013 and then stabilized in the 60% range. Lobectomy declined to 23% in 2009, stabilized, and then increased up to about 30% in 2018. So despite the fact that that was the preferred regimen, it still was only 30% by 2018. Overall, the non-surgical management did not change over time. And there were essentially, as she mentioned, they looked at all variables that could be associated with some of these changes. And there was essentially no difference based on sex, age, race, and ethnicity, whether they were in a metropolitan residence or not, and what their insurance was. Tumors greater than 4 centimeters, greater than or equal to 4 centimeters, interestingly, really did not change very much in their treatment patterns. 55% had total thyroidectomy plus radioactive iodine. and 27% were treated with total thyroidectomy alone. So what I found is this was very similar to a paper that was published a couple of years ago, where they were just looking at changes after the implementation of the 2009 American Thyroid Association guidelines. The findings of this paper showed that for micropapillaries, or 1 centimeter or smaller, the rates of lobectomy or hemithyroidectomy increased from 20 to 27%. There was an overall decrease in the rate of total thyroidectomy with radioactive iodine down to 7.1%. And that in 2016, basically 73% of people were treated with total thyroidectomy alone. For tumors 1 to 2 centimeters, they didn't go all the way to 4 centimeters. They showed that the rate of hemithyroidectomy increased to 11.4%, decreased rate of total thyroidectomy with radioactive iodine down to 25%, and increased rate of total thyroidectomy without radioactive iodine went up to about 67%. So these findings are fairly similar to what Dr. Pasqual and her group has shown. And this is just a picture kind of demonstrating those changes in usage of lobectomy versus total thyroidectomy with radioactive iodine. And you can see here that there was an increase in the total thyroidectomy group overall and a decrease in the total thyroidectomy with radioactive iodine, which is the darkest green here. So the conclusions of this study were that the ATA guidelines did appear to influence practice, but for the guidelines that were more strongly worded, they felt like that resulted in more change rather than you can use this or this modality, which is what the wording is for basically lobectomy versus total thyroidectomy. So back to the conclusions of Dr. Pasqual's group, they basically showed that the use of radioactive iodine in low-risk patients has declined significantly, consistent with guidelines not to use radioactive iodine or use it more judiciously in people with low-risk tumors. But what is very interesting is there's still overtreatment of some of these low-risk tumors. There were 6% of the micropapillaries, so less than 1 centimeters, who underwent both total thyroidectomy and radioactive iodine. And so that's actually not recommended any longer, but still 6% of people were getting that. Again, we don't know all of the details of the pathology, so we don't know whether there were more aggressive features in some of these low-risk patients. And that is one of the limitations of looking at a database rather than being able to look into the chart itself, but still 6% is higher than we would expect. The other observation was that lobectomy has not increased as much as would be expected based on the fact that it is the primary treatment for less than 1 centimeter tumors and is considered equal for those 1 to 4 centimeters. Only 25% of the low-risk tumors underwent lobectomy, and only 30% of the micropapillaries had that. The last finding was that non-surgical management was really not significant in either group. Now, my question, I guess, is that, can we really adequately capture this in the SEER database? Because the SEER database, it would assume that we know that this person has cancer. And so because the guidelines recommend that we really don't biopsy tumors that are less than 1 centimeter, it may be that we're not actually capturing all of these small micropapillaries less than 1 centimeter by biopsy because they may not be biopsied. So it could be that practitioners are doing observation or active surveillance based on high suspicion of malignancy because of ultrasound findings, but it's not actually something that's been recorded as a diagnosis of cancer. So that's one thing to think about when we think about non-surgical management or active surveillance in this population. So some questions that I had, coming out of reading this article is, how long does it take to change practices? So guidelines change. It's now been, almost 6 years since the last ATA guidelines were published, and so you would think that that's enough time to see change. But as we showed with the other article, that they were looking at 2009 guidelines and had looked at 2016 and had shown that not everything had caught on. So looking into that, this is an older paper published in 1999, but I think still holds true. Why don't physicians follow clinical practice guidelines? And so they basically looked at a lot of articles. They looked at 76 articles, including 120 surveys, and looked at 293 barriers to physician guideline adherence, and basically found that there are many factors that impede physicians following clinical practice guidelines. Awareness of guidelines is a big one. Familiarity with them. Are they in agreement with other guidelines out there, or are there discordant guidelines? Self-efficacy, outcome expectancy. What do the treating physicians expect to get from changing these practices? And then lastly, the ability to overcome inertia of a previous practice. It's really hard to change what you're doing if you've been doing it the same way for a long time. So it may be that a lot of those factors impact our ability to change practices over time, even though they have come out, kind of with strong recommendations. This is exactly the point of this group, TIRO, to try and make people aware of guidelines, and so that there is increased access to being aware of guidelines. So another question is, how many people are seeing physicians who see high volume thyroid cancer? And who's making the decision about the extent of surgery? So the thing that struck me is the adherence to not giving radioactive iodine seemed to be much more impressive than changing the type of surgery. And so I think that, kind of who is seeing them and making those decisions may make a big difference in what happens. So there have been studies published looking at surgeons and high volume surgeons and improving outcomes for patients who have thyroid cancer, in that if somebody goes to a surgeon who does over 25 surgeries per year, they are likely to have a better outcome than somebody who doesn't do that many surgeries in a year. But what about endocrinologist volume? I'm not aware of anything that has been published looking at, who patients see and who is counseling them to undergo what procedure. But we know that having multidisciplinary groups to discuss patients with helps with adherence to guidelines. But is everybody going to a practitioner, whether it be an endocrinologist or a surgeon, who is actually participating in multidisciplinary conferences where, the pros and cons of a lobectomy versus a total thyroidectomy, or whether they should have more or less aggressive treatment, is being discussed. So I think that sometimes, that gets back to if the practitioners are not either in agreement with the guidelines or not as familiar with them, are they recommending things that are not necessarily the newest guidelines? And then what is the reason for the total thyroidectomy rather than having a lobectomy, since this seems to be the biggest difference between the two groups in not maybe adopting the most recent guidelines? And so I guess some of the things that I can think of as the conversations that I have with patients almost on a daily or certainly a weekly basis is, are they already on thyroid hormone? Do they feel like it wouldn't, change much if they had both lobes out versus one lobe, in the fact that they would have to take thyroid hormone or not? Do they have contralateral nodules? And are we concerned about those, or is the patient concerned about having to continue to monitor those even if they have the other lobe out? Does the patient have anxiety about recurrence and they just want the whole thing taken out, even if the physician is reassuring, saying that that lobectomy seems appropriate? That, as I mentioned, the need for long-term monitoring, that gets to their anxiety about recurrence, and also maybe distance they live from their physician. If they, the author, Dr. Pasqual, and her group actually did a very nice job of trying to address this and looking at the different urban versus rural residences, maybe indicating longer drives for people to follow up. Maybe that impacts their decision to get a total versus a lobe. Even though they did not see a difference in their study, I still wonder whether that plays into some decision making. More recently, thyroglobulin initially looked like it may be promising to follow people with lobectomy, with just a higher threshold, but that has turned out to not be very useful. And so there's really no biochemical marker for people to follow with lobectomies as compared with total thyroidectomies. And so does that create some sort of change in behavior on the physician's part and on the patient's part? And lastly, Dr. Pasqual and her group noted that there was a steeper increase in lobectomy in 2015 to 2016 for those with private insurance versus those who had Medicaid or no insurance. And so does that signal that maybe there's some socioeconomic disparities in what's being offered to different people that we just haven't been able to tease out yet? So just one last thing about worry in thyroid cancer survivors. There was a nice study published in the last couple of years that reported worry in thyroid cancer survivors, even if they had a favorable prognosis. And you can see here that 40 to 60% of people were having worry about one aspect of thyroid cancer compared to other things. So 41% worried about death, 44% worried about harms from treatment, 55% worried about impaired quality of life, 58% worried about family at risk, and 63% worried about recurrence. And so this is not an insignificant thing to consider when people are deciding what they want to do for their therapy. With that, I'm going to wrap it up. But I think that this study is an extremely important study and pointed out a lot of things that we see clinically in our practices and need to figure out why is there some resistance to making the changes that the guidelines are recommending. And again, I want to congratulate Dr. Pasqual and her group on such a great study. So time will tell, I think, for future studies. Sorry, I'll unshare.
Awesome. Thank you so much. It looks like Dr. Pasqual is back, and so we're going to let her come back and finish up her presentation before we get to questions here.
Okay.
Great, terrific.
Thank you very much, and sorry for that. I don't know why my internet went down. So I'm really, really sorry about that. I will share the screen again. I don't remember when I lose you. It was at this point when we were looking at, okay, perfect, sorry. We were looking at difference by race and ethnicity in trends, and overall, these trends are similar across different race and ethnicity, as well as also between metropolitan counties and non-metropolitan counties. Although there is a bit of noise for non-metropolitan counties due to the number, the sample size for this group. Insurance status is available in SEER only between 2007 and 2016, but we were able to see this decrease in the use of radioactive iodine for both insured and uninsured patients, as well as this increase in total thyroidectomy alone. And as also pointed out just now by Dr. Goldner, we can see that it's not really clear if there is an increase in the use of lobectomy for uninsured or Medicaid patients around 2015. So to summarize, total thyroidectomy followed by radioactive iodine declined substantially, and most notably for microcarcinoma. Total thyroidectomy alone rose from 2000 until about 2015, after which we see kind of stabilization. And lobectomy slightly decreased between 2000 to 2006, stabilized, and then slightly increased again. And we did not observe any changes for the no surgery category, which includes the active surveillance group. So what we see is that there are subtle changes in the use of lobectomy and almost no changes for the use of active surveillance. And I will be really interested in hearing from like a clinical community how they interpret those observations. The literature has pointed out there are barriers in the implementation for lobectomy and active surveillance, where patient and physician factor influence the decision over lobectomy versus total thyroidectomy. And these are not related to the tumor characteristic, but for example, include physician volume, physician numbers of year in practice, patient access to care, or patient preference. And also research has shown also that even if the majority of physicians think active surveillance is a viable option, few of them really offer this to patients. And there are worries about, for example, patients' ability to follow up, and also worries about malpractice. So it has been cited as possible barriers in the implementation of active surveillance. It's also true to say that active surveillance was introduced as an option in 2015 adults guidelines. And just for a comparison, the use of active surveillance for low-risk prostate cancer took about 20 years to be implemented and becoming the most used option. Although, again, the discussion here is what has been learned for active surveillance in low-risk prostate cancer can be really applied for thyroid cancer patient, as the average prostate cancer patient is completely different than the average thyroid cancer patient. And it's likely that with more research and clinical trials showing the safety of this option will probably increase. Especially also because they offer the advantage of avoiding lifetime use of thyroid hormone. But also research has also pointed out that probably some decision aid tools are needed to help a clinician and patient to navigate the decision about different treatment options. I want to talk a bit about the strength and limitation on using SEER database for this type of analysis. The biggest advantage of using SEER database is that we are using a large data set representative of the general US population. SEER database is one of the most high quality cancer registry worldwide. And also this allows, it's a cancer registry that allows really comprehensive analysis, for example, the inclusion of pediatric population and the ability also to stratify for some patients' characteristics like race, ethnicity, for example. We have to be aware of the limitation of using SEER database for this type of analysis, including, first of all, the fact that we only see the first course of treatment. So we probably underestimate the use of total thyroidectomy or radioactive iodine if those treatments are used over a recurrence. We also lack of data on administrative dose of radioactive iodine, so we couldn't evaluate trends in the administrative dose of radioactive iodine. And also there is a potential for underestimation of use of radioactive iodine due to the fact that if radioactive iodine for some patients is recorded outside the medical records that are revised by SEER, although this type of under ascertain is likely not differential by year. So the trend we see, it's very, very likely to be a true decreasing trend. The other limitation is that that SEER do not record active surveillance for thyroid cancer, so we had to use this proxy. But of course, this proxy no surgery include also patients that did not receive surgery because of the other reason than active surveillance. So take-home message to conclude, radioactive iodine use in low-risk adults and pediatric papillary thyroid cancer has declined by more than 50% between 2006 and 2018. And this is consistently with changing the American Thyroid Association guidelines. And post-2015, trend in the use of lobectomy and non-surgical management of low-risk papillary thyroid cancer, and particularly microcarcinoma, were more subtle than expected. There are some few questions that remain, I think, after this work. One question I will be really interested in seeing is radioactive iodine administrative dose over time. although SEER database is not appropriate for this type of analysis, and probably more hospital-based data set are more appropriate for this type of analysis. And also we see some clue in our analysis of some socioeconomical disparities in treatment, such for example, the fact that lobectomy did not increase for uninsured Medicaid patients, or that different distribution of race and ethnicity in the no surgery group that may indicate that may indicate the existence of some socioeconomical disparities. I want really to thank all the co-authors on this project, especially my supervisor, Dr. Karikitara at NCI, and I leave here the reference for the studies. And I'm happy now to answer questions and to have the discussion. And again, I'm really sorry for the interruption and the problem.
No, don't be silly. This was terrific. And thank you for not only presenting this morning, but as Dr. Goldner mentioned, thank you for putting all the work together to bring this to us in your study. There are a number of questions from the audience. I have one burning question, and then I'd like to have Dr. Goldner pose some of the questions that she brought up in her discussion. I think one of the real burning issues that is how do we get a handle on a really difficult problem, which is assessing what is the impact of these change in trends, not on mortality, but on recurrence in this population. Obviously, you know, that's the really one of the big important questions. We've adopted changes here in terms of the extent of surgery, the use of radioiodine, and in some instances, obviously no surgical or treatment at all. How can we get, as an epidemiologist, can you help us to figure out, how are we going to figure out whether this population who've been exposed to less treatment are at risk or experiencing a greater incidence of recurrent disease?
Yeah, so this is a question, for example, we cannot answer in SEER, and the reason being that recurrence of thyroid cancer is not well recorded in SEER. So that's a limitation also of using this database. So I think that for this type of question, which is like a more clinical question, and looking at survey and looking at recurrence in patient, I think you need really like some hospital-based cohort where you follow that patient and you look at recurrence over time, and also like clinical trials. A month ago, it came out that clinical trial in the New England Journal of Medicine looking at use of radioactive iodine in low-risk thyroid cancer patient, and they compare the efficacy of radioactive iodine, and that was a clinical trial.
Great. Whitney, I'm going to give you a chance here to ask any specific questions that you had posed.
Sure. So one of the questions that I had, you mentioned with the active surveillance, that was a little bit hard to capture because it was other. In the United States, we aren't necessarily recommending that those nodules even be biopsied at less than 1 centimeter. So I wonder if, that's also a limitation in looking at active surveillance, because if they haven't been biopsied, they won't actually be considered a cancer. It may be in the physician's mind active surveillance because of high risk imaging characteristics or something, and they suspect a cancer, but it wouldn't necessarily make it into the SEER database unless there was some sort of tissue diagnosis. Do you think that that could be contributing to some of the low numbers there too?
Yes, totally. So that's also really a limitation of using a cancer registry, because like to enter in a cancer registry, you need a biopsy, like the confirmation of cancer on a biopsy. So we are losing for sure those nodules that are not biopsied, but they are followed up. So for sure, I think that's one of the reasons probably that we probably underestimate a bit the use of active surveillance. So yes, exactly. So basically, these type of registry do not capture those patients who do not have a biopsy diagnosis of cancer, and for which active surveillance is proposed.
Great. We have a number of questions from the audience. I wonder if I could pose these. One question that really relates to management during the pandemic, and whether or not you feel that this has possibly impacted the trends in de-escalation from 2000 over the past several years. Obviously, that's going to be beyond the time frame that your study was. Wondering if you have any thoughts regarding that.
That's really an excellent question. So to look at the data of pandemic, we will need to wait few years more in SEER, because the release of data, because they need time not to collect data. And for sure, I think that will be very interesting in seeing that. And that's really a question also in the, I study effect of medical radiation. And one of the effects that that was observed is that during the pandemic, there was also a decrease in imaging. And this is due to the fact that patients were not, like, there was, especially now in the first moment when there was really high restriction. And so, like, my expectation will be that we will see a decrease in some therapy, or at least probably, you know, and also probably a decrease also in the incidence of cancer because of the delay in diagnosis.
Great.
If you don't mind, I would agree that I think that it might be a combination of just what I felt like I saw clinically is either it's a decrease in the diagnosis overall because people didn't get imaging, but I do think that the tendency towards a total thyroidectomy rather than a lobectomy with a potential second surgery was the inclination to do a total thyroidectomy if they were actually going to have surgery was higher because of all the restrictions on, you know, OR time and things like that. So if they were people that were going to actually have surgery during the pandemic, they didn't want to come in twice. If there was if this turned out to be something that they needed a completion for. So I think that will be an interesting observation too. I know that's not part of your current data, but that might contribute to some of the total thyroidectomy data.
That's interesting. There's a question from the audience regarding whether the trends in the US are reflected of trends elsewhere in the world. Do you have any sense on that?
Not really. I'm not really aware of similar papers on other, like in other parts of the world. And we were like, the reason of focusing on the United States is because we wanted to look at changes in relation to the American Thyroid Association guidelines. At the same time, more or less, our paper came out on thyroid. There was a paper from Italy also come out that shows also that we're looking at yes, rates in thyroidectomies also. But I don't really know how these trends really are in other parts of the world.
Okay. There was a question regarding difference in trends related to ethnic minorities and whether or not you would project that what accounts for those differences? Is it a question of resource availability or cultural differences in disease perception? Do you have a sense on that, or would you project?
I think it's probably like we probably there is like multiple reason here, and and I think our data in SEER are not really appropriate to see like differences in socioeconomical status. Like the analysis we have done is very broad, and probably we need more detailed data on socioeconomical status to really understand what are the driver of these differences. Residency can be one, because of course, if a certain treatment means traveling more, losing days of work, then of course I think that counts, at least in the decision of the patient, and also insurance status also seems really to count. So I think this we really need more detailed research on socioeconomic disparity and racial disparity to really understand what are the drivers of these changes and also tackle them.
Great. This is a question for both of you. You did mention changes in prostate cancer management and the particularly long lag time from guideline evolution to adoption. Do we have any other data in terms of either other disease processes with respect to lag in adoption for significant disease management changes here?
I don't know if you want to go first.
Yeah, I'm not sure that I can think of other disease processes specifically, but I always do think of prostate cancer and thyroid cancer as being very similar in their, in the way that they have evolved. They are both, have a large proportion of low risk patients, and there was a period of overtreatment for both of them, but yet there are some that have higher risk features and need to be, aggressively treated. And so I look at them as being very, very similar entities. And I think that because there is that higher risk group in there, I think that there's fear on the side of the patients and probably the treating physicians that they're treating one of those higher risk people with, not enough treatment or under treatment. And that maybe is what prevents the guideline implementation from going a little bit faster. That's just my observation from the prostate cancer side of things, but they do seem to have a similar course.
Yes, I also wanted, my association was prostate cancer, but I think one of the differences is really the age of the patients, that I think maybe it's important in the decision making, because for a young patient thinking about maybe a lifetime surveillance, it's maybe a much more burden than like an older patient. So probably those factors also are needed to also be taken into account, but yeah.
Dr. Pasqual, in 30 seconds or less, can you give us a sneak preview on your research association between obesity and thyroid cancer?
I'm currently now working on a study. I actually submitted an abstract to the American Thyroid Association meeting in Montreal. And I'm working with the sister study cohort, which is a cohort of women in the United States that is maintained by the National Institute of Environmental Health. So this is an ongoing work. And I know that there is a lot of interest in this topic.
Great, terrific. Well, thank you both. We are up against the 9 o'clock hour. I really appreciate both of your efforts. We had a number more questions from the audience that we were unable to get to, and I apologize to them. As always, these for those of your colleagues who were not able to join us, this recording will become available and permanently a part of TIRO at the beginning of next week. I'd like to invite you all back next week on a topic that Dr. Pasqual has particular interest in, and which is related to the risk of developing secondary malignancy following radioiodine therapy. So with that, I wish everybody a great day, and everybody stay safe, and hope that we'll see you back next week. Thank you both.
Thank you so much.
Thank you.
Bye.
Bye. Have a good
Bye.
day.